do a commercial for PATH, I promise, but for those of you that don't know about PATH, PATH is a Seattle-based international NGO. We work in about 70 countries around the world. About 1,500 folks work with us, most of them in those countries. And our focus, the 40 years that we've been in existence, is really trying to tackle this issue of equity and figuring out how to improve lives for those who are most vulnerable. And this is the current countries in which PATH works. And I wanted to show this map to get started for the talk. I'm sure many of you have seen these kinds of depictions. This is World Mapper, but basically what they've done is to take conditions, including health conditions, and plotted them on a world map, but distorted that map to reflect the actual incidence of that problem. And this is a classic one from them for infant mortality, infant deaths. And I like these because I think it really, in a visual way, depicts the profound health disparity that we face in the world and really gives us a sense for the kind of work that and challenge that we need to do to confront this. Because underpinning this health disparity issue is really an issue of health equity. And let me just briefly talk with you about that. These are my two daughters from a while ago in Namibia, in the northern part of Namibia. And I like this picture because to me, working at the Gates Foundation, where the premise was all lives have equal value, and they do, this picture brought home to me that all lives do have equal value, but we're all not starting at the same place. And the opportunities that have been afforded to us through where we've been born and where we've grown up have a profound influence on our ability to be successful and our ability to be healthy. And it was only after I took this picture that I saw my daughters were wearing rodeo romance and Camp Beverly Hills, which I think really adds this notion of the profound inequities that we have in the world. And so let's talk a little bit about that, about health equity, which at least in my mind is that maybe achievable, maybe unachievable state in which everyone has the opportunity to achieve their full health potential. It's a grand goal. There are a lot of things that influence that, including income and oppression, things that we care about but maybe are not directly working on. What I want to focus my talk on today are things that actually collectively in global health, and looking at this audience, you have the ability to influence, and particularly recognizing that from a health equity standpoint, no one should be disadvantaged from achieving health equity as a result of a remedial circumstance, and in particular, the health system that serves them. We as the health system that are serving people should not be creating health inequity by virtue of what it is that we are providing. In my days doing domestic health in this country, and I'm sure you have seen this as well, oftentimes the healthcare system is described as being really trying to achieve these three outcomes of quality, access, and cost. Low cost optimally. And these are the things that really drive our work. But the frame that many of us have, in essence, grown up with is that you have to pick two of those three, that there's a trade-off here, there's a steady state, and if you want to achieve quality and access, you need to be sacrificed cost. If you want to achieve cost, you need to have some quality or access constraints. And the premise of what I want to talk to you about today is that we need to suspend that notion as we're thinking about the nature of innovation to tackle health equity. So let me now walk you through 6 examples from PATH where you can decide whether we've been successful, but I think the intent was to try to suspend this notion and try to achieve all 3 of these at the same time. First, back to infant deaths, and this really reflects PATH's backgrounds. There are a number of life-saving interventions that we have in our healthcare system that just require minor modifications for them to be as effective in low-income settings. I put 3 up here. Oxytocin, which is a primary drug to prevent postpartum hemorrhage, in the world that can deliver it is delivered intramuscularly and has to be delivered through a syringe. In much of the world where women are delivering, neither of those are available. And so simply shifting the formulation of oxytocin into a fast-dissolving, heat-stable tablet that does not require a cold chain and can be administered by a layperson would be an example of innovation to achieve equity. A second example would be in an intensive care unit setting, particularly a neonatal intensive care unit setting, you need to be giving oxygen. And you need to be giving oxygen at high concentrations, but not 100%, because that causes retinal damage. In much of the world, the equipment that we have that does that here doesn't work because the electricity goes out or there are other constraints. Simply changing the mindset of saying, well, the way actually to deliver oxygen at a defined concentration doesn't have to be through an electrical means. Simply a mechanical valve that you can slide up and down the pressured gas that is coming out of the oxygen tank can allow you to get the same precise oxygen concentration that our systems do. Third one is intravenous infusions. In this country, life-saving, require electric generators, electricity, to make sure that the drug is being properly administered. Simply converting the source of power from electricity to a manual pump, a bicycle pump that you can pump into something that's called the Relied Delivery System, creates that opportunity for this life-saving medications to be delivered in settings where there's no electricity. So that's my first example for you. 5 more examples, I'll go quickly, but I think each of them involves a different way of thinking about this nature of innovation. I want to talk with you about meningitis, and particularly meningitis in sub-Saharan Africa, the Sahel region of sub-Saharan Africa, which is the background. And this is a picture of some kids from about 5 years ago that were actually receiving the first meningitis vaccine that was available for this area. I've been warned that the slides are going to go on and off a couple times because it's 5 o'clock, so that's why we're getting the light show here. Until recently, about 90% of global meningitis occurred in that belt of sub-Saharan Africa, and one serogroup, Group A, was the responsible cause. This is an entity that's eminently amenable to a vaccine. But the problem was that the vaccine manufacturers in the rich world said, we cannot create this vaccine using our business model at a price that is going to be affordable and therefore used in sub-Saharan Africa. And so the innovation here was to say, can we disrupt that price model by thinking of an alternate way of doing this? Funded by the Bill and Melinda Gates Foundation, working with WHO and FDA, PATH helped transfer the technology to create conjugate vaccines from the rich world to a Indian, Serum Institute of India, low-income vaccine manufacturer. They have a different cost structure. We, by providing the technical assistance, defrayed some of the upfront research costs, and they were, over the course of 3 years, able to produce a high-quality conjugate vaccine that sold at 25 cents a dose. And this was the day where it was launched. Since then, this Menafrivac, as the vaccine has been called, has been rolled out to over 300 million people. And the amazing story here is that meningitis has disappeared. Group A meningitis has disappeared in the sub-Saharan meningitis belt. All the countries that have employed this vaccine have essentially seen 0 cases of this disease, and that has transferred to unimmunized in those same countries as well. And so the reason I didn't show you a world map or map for meningitis is because that map now would show that there is no meningitis in these countries, simply by the simple intervention of, can we create a different cost model to create health equity in these countries by providing them a vaccine that is one they can afford. Third example, immunizations. The World Mapper actually shows that immunization rates around the world are not that dissimilar, but the sad reality is that still about 1 in 5 children in the world are not receiving recommended immunizations. That's particularly a problem in sub-Saharan Africa, where the risk of these diseases is quite high. And so how can we tackle that? The problem, this is Beatrice, she's an immunization nurse in Tanzania, is the conditions under which she's trying to deliver immunizations are awful. There are no data systems. There were no data systems to tell her who was going to be coming in that day. There was no way for her to track kids that were not coming in. There was no way for them actually to track vaccines and know whether or not the supplies they had on hand were a match with what they were going to need that day. The simple intervention was to go in there and to use something that is in place in this country for different reasons, but to create a electronic immunization registry using mobile handheld devices for data entry and a patient-level system that can then provide Beatrice with the information that she needs about kids coming in and about vaccine stock. And a system that not only can optimize the delivery of care at the clinic setting, but can generate real-time population-wide data to enable the health ministry and others to actually plan their immunization programs. And again, it works. It's very simple. About 500,000 kids have been enrolled in this. And Beatrice and her colleagues now spend about 41% less time registering and vaccinating children than they had before. This simple innovation has created an amazing efficiency in their system, including efficiencies in reducing the reporting burden. And the data are being used. And so now in Tanzania and in Zambia, where these are being implemented, kids who are not coming in are being identified, community health workers are being tasked to go out and find those kids, and now that vaccine supply chain is based on real-time data for what vaccines are being needed. Again, simple innovation, but remarkable results. A couple more. We heard a lot about tuberculosis in the first hour of this session. Tuberculosis, as you know, is the leading cause of infectious disease mortality in the world. And as you can tell by this map, about a third of all tuberculosis cases actually occur in India. And if you go to India, much of that disease is occurring in urban slums, which have people who are inherently at risk for tuberculosis and who are living in conditions where spread is intensified and, importantly, where medical services are lacking. So the place where arguably the disease has been the biggest problem is also the place where the healthcare system has had the least ability to provide services that people need. And in Mumbai, in the slums, and this is actually true now around the world, increasingly slum residents are not going to government sector clinics to receive services. Those clinics are oftentimes far away, they're oftentimes poorly staffed, and are not able to meet the demand of people that come in. So in Mumbai, about 70% of the people with tuberculosis are seeking care in the private sector. And that is a range of private sector providers, from well-trained clinicians all the way down to people with very modest training. And historically, there's been no recourse that those private providers had to improve the quality of care that they were giving. So the innovation here was to say, working with the government of India, rather than trying to force people who potentially have tuberculosis to come into understaffed public clinics that they're not going to use. Instead, can we increase their access to quality medicine by directly working with the private providers to make sure that those private providers have access to the same diagnostics, the same therapeutics, the same case follow-up that you are providing in the public sector. And it was remarkably successful. Through a system of vouchers, patients who were suspected of having tuberculosis in the private sector were now able to receive free of charge chest x-rays and gene expert diagnostic testing. No mobile phones yet, that'll be the next thing that we do for the cough. They were able, if the diagnosis was confirmed, to have access to free medicines, such that they would have had if they'd gone to the public sector. And if they were lost to follow-up, the community health workers for the public sector would go out and find that patient. And most importantly, they could continue to be seen by that private provider, which is who they wanted to see in the first place. And that private provider now is cooperating with the public sector because they're not losing their patient, they're getting an asset by the patient. And it's a double win, because when you look at it from the government standpoint, the resources that they're spending on these patients are actually fewer than they would spend providing all of the care if that patient came into the public sector. This is case notifications per 100,000 population. About 65,000 cases were diagnosed in this pilot. And what it shows is that there was a dramatic increase in the reporting of tuberculosis, the identification of cases, almost all of it from as a result of the private sector engagement, which had not been there before. And it works. Success rates for treatment in these patients were comparable, if not slightly better than the public sector, and about 80% of the patients had a completed course and cure. This model has now been expanded throughout India to about 2 million TB cases in 400 metropolitan areas, and represents a substantial advance in how to achieve, at least in my opinion, health equity by changing the model of how we think about access. Two more. Second to last one is malaria. Malaria obviously is a huge problem, particularly in sub-Saharan Africa. And I want to talk with you a little bit about some of the progress that's been made. There's been a lot of talk about malaria elimination, whether or not it's feasible. It is, but how you get there. And historically, what folks had done was to say, well, if we take all of the strategies that we are using to combat malaria and deploy them simultaneously and expertly, we can eliminate malaria in a region. And it turns out that that's not true. What happens is that as the prevalence of malaria in a community goes down, an increasing proportion of the people who still have the disease are asymptomatic, are not sick, but are serving as the reservoir of Plasmodium when a mosquito bites to spread to others. So in order to actually eliminate malaria, you have to eliminate the asymptomatic infection that occurs in a community. And there are technologies to do that, including rapid diagnostic tests that will demonstrate when people are carriers but asymptomatic, as well as this notion of when you identify cases, going in and not only treating those cases, but treating the community around that case so that you're simultaneously treating the individual, but treating and eliminating the reservoir that has been serving to promulgate the disease. And it's been this part of it has been remarkably successful. Using community health workers, changing that notion of access for, rather than expecting people who are sick to come in, having the healthcare system go out in the community and take measures. When this started in 2014, the red just north of the lake there in this part of Zambia represents the parasitic prevalence. I'm going to go forward by year. And remarkably, there has been this substantial reduction now in the community prevalence of malaria that is leading to this part of Zambia, which was hyper-endemic, now being on the list of one of the first places to actually be able to eradicate malaria, probably within just a couple of years. Last one, maternal mortality. Again, just a horrible health disparity, horrible inequity. Today in Africa, 1 in 26 women of reproductive health age dies from some sort of maternal complication. And that compares to, in the US or in Europe, about 1 in 10,000 women. Huge disparity. About 200 million women in the world, many of them in sub-Saharan Africa and India, who do not want to who are not planning a pregnancy, do not want to become pregnant, don't have access to modern methods of contraception. And the vast majority of unplanned pregnancies come from those 200 million women. And then to get on my soapbox for a minute, beyond just the health issue, I think from a human rights and equity issue, we can all agree that every woman has the right to be able to control her health, her access to reproductive health technology, and ultimately her sexual and reproductive health. So how do we begin to tackle that last portion of women? Not through malaria prevalence. Well, Well, there's just one example of this new product that's become available recently. It's a formulation of Depo-Provera, which is a long-acting contraceptive that's injectable. Depo-Provera, though, in most instances, actually needs an intramuscular injection and needs to be delivered in a clinic. This formulation is actually a subcutaneous packaged injection device that takes less Depo-Provera and opens up the possibility, actually, of women injecting themselves and not having to go into a clinic to receive the medication. And that's actually been happening now across many countries in sub-Saharan Africa, where community health workers are going out and for women for whom this is an appropriate choice, teaching those women about this product and teaching them self-injection so they don't have to necessarily come into a clinic, disclose to the world that they're seeking contraception, and also can have this now at home where they don't have to make the long journey to the clinic each time they need an injection. 20 countries are now in the process of adding this to their armamentarium of contraceptive devices, and this is really putting control and self-care into the hands of the individual rather than relying on the healthcare system to do it. And remarkably, this shows that women who start self-injecting, actually, when you go back a year later, they're much more likely to be continuing to use contraception in this method of contraception than women who are coming in and receiving the more standard injectable Depo-Provera. So this is not only increasing access, but it's increasing use and increasing quality of the product. Okay. So hopefully stimulated you a little bit. I'm going to just run over the 6 ways that, at least in my mind, we should be thinking about as strategies, innovative strategies to improve health equity. One, those development and use of essential drugs, diagnostics, tools that actually are catered for the delivery system in which they're being used. Pretty simple. That's what PATH has been around doing 40 years, but there's still room there. Another is to just reduce the cost of expensive tools, devices, biomedical products by taking advantage of market approaches and seeking to have those developed in low and middle income countries using their economies, their wealth, their wage scales, and creating jobs locally as well. The third is recognizing with digital, we now have the ability to act on what we've always known about adaptive management, continuous quality improvement, but now even in relatively low-resourced healthcare settings in low and middle-income countries, you can implement systems, electronic immunization registries that allow you to do that. Leverage the private sector. My goodness, more and more of the world is seeking healthcare in the private sector. In many places, the private sector is the provider to the rich, but I think there's a new model here that says increasingly the poorest people in slums around the world are using the private sector, and let's leverage their expertise and get them to work in public-private partnerships to deliver needed healthcare. Task shifting. Let's talk about moving the locus of care, even when it involves the healthcare system, as close to the front lines as possible, using people who are adequately trained, but no more than adequately trained, so you can reduce costs, and moving care into the community. And then self-care. At the end of the day, particularly again with advances in digital learning and new modalities and devices, there's an opportunity to use that. I want to conclude by a couple of things. First, this quiz. Can anybody guess what this map is showing? What health condition is this map showing? Immunization would be a go. It looks like it, but actually it's not. And this is looking into the future. It's men smoking. And increasingly, what we need to recognize is that as we are successful in reducing deaths and morbidity and mortality from infectious diseases, we're creating an epidemiologic transition around the world, particularly in low and middle income countries, where their problems are becoming our current problems, be it tobacco use or obesity or diabetes. And as a consequence, as we think about these methods for innovation to achieve health equity, we need to now take a step forward and say, how can we in advance begin to think about health equity as it pertains to the problems that are emerging in low and middle income countries, not just the problems that are the ones that we're having some success. And so what are the innovations for managing diabetes and obesity? A lot of this is going to move towards the need to provide true ongoing primary care, but beyond that, we need to be recognizing that as we're successful, we need to be innovating in what's coming. And to challenge us a little bit, not all of the health inequity in the world is in Africa. And as we think about children, no matter where they are, and this little boy is clearly not in Africa or India, need to recognize that our kids in particular are vulnerable, and that their vulnerability is just as impacted by issues around health equity potentially as the children that we've been speaking about in Africa. And so to finish that thought, I wanted to put up this picture of Seattle, just to say that this is not about global health meaning what's happening over there. It's really about global health and issues of health disparities and equity as it applies right out here and right outside our door. In former life, as you heard, I was the health commissioner for the city here of Seattle and King County. And one of the things that was really remarkable to me as I started that job, I came there from the Gates Foundation with their focus on equity, was how much equity, and in particular inequity, is a driver of health in our area. This is a map of Seattle and King County. It's color-coded by census tract. Each census tract is about 10,000 people. This is life expectancy and shows the profound difference that we experience by life expectancy, even in this beautiful city in which we live. And you know, it's funny, in public health in this country, as people have aggregated statistics, generally county is about as low as our public health statistics go. And if you do that, King County is like Lake Wobegon. We're basically above average on everything. But what is hiding in that tyranny of the average is the stark reality that that number is only an average for us. And the disparities that we have by census tract within King County vastly outweigh the disparities that we have by county within this country. So as we're thinking about these issues of disparity, we need to switch our paradigm, recognize that this is just outside of our door, and that unfortunately, the problem is all too common. You may not be able to read this, but this is that map I just showed of life expectancy on the top left, and then have plotted other conditions: tobacco use, frequent mental distress, adverse childhood experiences, lack of physical activity, obesity, diabetes, preventable hospitalizations. The remarkable thing that comes out from this is, number one, again, how health equity and health inequity is something that we all need to be worrying about just for our neighborhoods. And second, that it kind of doesn't matter which health condition you're looking at here. The maps tend to be the same, and they tend to track where people are marginalized, where there are communities of color, where there's poverty, where there's substandard housing. So I started this by talking about the need to think about the health system as the system in which we can be making a difference on equity. And I'd like to conclude by asking us to say, yes, that is true, but we need to expand beyond just the health system in our concepts of how we're going to correct equity, because fundamentally it's the communities in which we live, work, and play that are the primary drivers of our health. And we as health advocates and health system professionals need to recognize that we need to be moving the locus of our work from just our clinics out into the community to make that difference. Thank you very much.
So I'll start out with a question. That was really wonderful talk. You spoke about, in the context of tuberculosis, you spoke about providing access to treatment. One of the key issues in many developing countries, especially India, is illiteracy in these poor neighborhoods. So Are there any strategies that you hope to incorporate in the future to educate the public more and go more in the realm of prevention in addition to intervention?
So absolutely. And I think what we need to do, just to take your example, is to recognize that health education, as we have traditionally defined it, which is oftentimes with a pamphlet or brochure, doesn't work even when you can read. And how we work to educate folks and how we work to get it so that people see that the healthy choice that they want is actually a choice that's achievable needs to use an array of different modalities. Starting with picture books, comics, which is one of the things that has been very effective in Mumbai. But then going beyond that to say, actually, if you want someone to pay attention, they need to be talked to by someone that looks and sounds like them and is someone that they respect. And so, a clinician is not generally going to be the best source of motivation for a patient. And so one of the things we've looked at, for example, is using the simple device now that so many people have smartphones, of creating videos that are created within the community by community members, oftentimes community members who are respected, and then sharing those videos at, in essence, parties, so that people can see and hear messages that are delivered by and resonate with their needs, not with the needs that I or somebody else, from a more clinical perspective, would provide to them.
Great. Thank you so much for the wonderful talk. Let's give David another round of applause.
Thank you.